This 40-year-old male sustained injury due to his knee striking the dashboard in a car accident 6 hours before admission. There was pain, swelling, deformity, loss of function around the right hip. He could not stand up or walk, nor could he lift the luminae. The systemic and the general examination, which were not contributory, the local examination of the left hip revealed a flexion, adduction, internal rotation deformity with true shortening above the trochanter. Active straight leg raising was negative. Vascular sign of Narth was positive. There was no neurovascular deficit. And a globular swelling, globular bony swelling, a globular bony swelling was felt in the gluteal region, which moved with movement of the lower leg. Clinically, the diagnosis was traumatic posterior dislocation of the hip without neurovascular deficit. Points in favor were dashboard injury, pain, swelling, deformity, loss of function around hip, flexion, adduction, internal rotation deformity with true shortening above the trochanter, positive vascular sign of Narth, and a globular bony arch swelling in the gluteal region which showed transmitted movements. Differential diagnosis was fracture dislocation of the hip, where the posterior margin of the acetabulum may have been fractured. Central dislocation of the hip, where the Morris's bitrochanteric test would have been positive and the head, the pelvis could have been felt perrectally or pervaginally, or anterior dislocation of the hip, where the deformity would have been flexion, abduction, external rotation with true lengthening and apparent lengthening. And in this, the chances of vascular compromise of the femoral artery would have been higher. We would investigate the patient. We will splint or put the patient on traction. We would prepare him for general anesthesia. We would investigate to assess fitness for anesthesia and surgery. We would image by an X-ray of the pelvis, KP view, with both hips in height, parallel to each other and parallel to the trunk. Both lower limbs parallel to each other and parallel to the trunk. A broken Shenton's line would indicate a posterior dislocation of the hip. and a misplaced head would indicate a dislocation of the hip. We would carefully try to look for a fracture of the posterior rim of the acetabulum, if necessary by 3D reconstruction CT, to determine whether the reduction would be stable or not. Under anesthesia, patient would be on the floor. He would produce the deformity, that means flexion, adduction, internal rotation, with the hip and knee at 90 degrees. We would apply vertical traction on the femur while holding the pelvis and applying counter traction. And as the length is restored and a sound is heard, you would take the knee outside, that means abduct, externally rotate the hip and extend it. We would check for instability in 90-degree flexion by telescoping the thigh. We would immobilize an abduction and external rotation for 3 to 4 weeks, in which isometric exercises and straight leg raising would be given to maintain muscle tone. Then we will promote gradual weight bearing. First with support, then without support. If the reduction fails, if the closed reduction fails, then the causes are from outside in: contracted pelviacetabular muscles, hourglass contracture of capsule, inverted labrum acetabulare blocking the reduction, hypertrophic ligamentum teres. In this case, we would open the hip by a posterior approach, take care of the hourglass contracture by releasing the iliopsoas from the Lisette canter, take care of the inverted labrum acetabular, take care of the depth of the acetabulum, reduce the hip and fix the posterior rim of the acetabulum to provide stability. In case of very old cases, we would do a pelvic support osteotomy. without history of injury, if we get the same physical signs with a waddling gait in child, maybe bilateral, then it is congenital dislocation of the hip. The principles of management are literally the same. The Ortolani and Barlow test are positive. So you use the Ortolani to reduce. You retain by a plaster in broomstick plaster. And you rehabilitate when the dislocation is stably reduced. In case closed reduction is not possible, you follow the same sequence of open reduction. And in case of a chronic case, you do a pelvic support osteotomy. The pelvic support osteotomy is an osteotomy at the level of the ischial tuberosity, osteotomy of the subtrochanteric region at the level of the ischial tuberosity, which is usually open wedge, and the valgus angle is equal to pelvic angle. The osteotomy prevents adduction and abduction and progressive proximal migration of the upper end of femur. The two other causes of posterior dislocation of hip, non-traumatic causes, are septic arthritis in children, where when the blood is drawn from the femoral vein, the needle may infect the hip. Or tuberculosis stage 3. If the hip is painful, then we can do Britton's arthrodesis, which is pelvic support osteotomy with ischiofemoral extra-articular fusion of the hip. If painless, only a pelvic support osteotomy may suffice. Another way to deal with congenital dislocation of the hip, the pelvifemoral contracture, is either lengthen the contracture by a skeletal traction, gradually abducting till the hip is reduced. This was described by Dr. R.C. Gupta of the Allahabad Medical College. Or you shorten the femur in the subtrochanteric region to achieve reduction, which is the more preferred method practiced now.